Hello, my name is Sarina Pasricha, and I'm a gastroenterology fellow at the University of North Carolina. On behalf of my co-authors, I would like to thank the ASGE and the editors of GIE for allowing me to publish and present my research. The title of our manuscript is Sex and Race Ethnicity Differences in Patients Undergoing Radiofrequency Ablation for Barrett's Esophagus. Results from the US RFA Registry. The aim of our study was to assess sex and race ethnicity differences in the characteristics of Barrett's esophagus in patients undergoing radiofrequency ablation for Barrett's. Additionally, we investigated the impact of sex and race ethnicity on RFA treatment efficacy and safety outcomes. We used the US RFA Registry, which was a nationwide registry of Barrett's esophagus patients receiving radiofrequency ablation for Barrett's. This included 148 different centers from both private practice and academic sites. The registry does not mandate protocols for care, but does provide a suggested protocol for treatment and surveillance. Patients are included in this registry if they have 1, endoscopic and histologic evidence of Barrett's, and 2, if they are being treated with radiofrequency ablation. The safety outcomes that we looked at included esophageal perforations, stricture formation, which was defined as a narrowing in the esophagus requiring dilation, GI bleeding, defined as patients who required packed RBCs for blood transfusions or hospitalizations, and hospitalization rates itself. In terms of efficacy, we looked at rates of complete eradication of intestinal metaplasia, rates of complete eradication of dysplasia, and the number of RFA treatment sessions required to achieve efficacy of treatment. Efficacy analysis was restricted to patients who'd been in the registry for at least 12 months beyond treatment initiation and had at least one biopsy 12 months or more after treatment initiation. In total, we had 5,521 patients with Barrett's esophagus enrolled in the US RFA Registry. Of these patients, nearly 75% were male and about 90% were Caucasian. We found that there were marked differences in Barrett's esophagus disease patterns noted between different sex and race ethnicity groups. In this registry, females and non-Caucasians had shorter length of Barrett's esophagus and less aggressive baseline histology compared to males and Caucasians, respectively. Additionally, there was a complete lack of male sex predilection for Barrett's esophagus in African Americans and Asians. The reason for this different sex ratio in the races is unknown. Perhaps the differential effect is related to obesity, differences in diet, cultural differences in healthcare utilization by sex, or referral bias by physicians, all of which might play a role in detection and severity of Barrett's. In multivariate logistic regression analysis, strictures were almost twice as common in females compared to males. Additionally, Asians had a significantly higher stricture rate compared to Caucasians. The reason for this increased stricture rate in females, African Americans, and Asians remains unknown. Whether this represents differences in the healing process by sex or race, differences in the depth of injury, or other factors is unclear. In our registry, there were no sex differences in complete eradication of dysplasia or complete eradication of intestinal metaplasia rates in multivariable analysis. I do want to make note and pay attention to the fact that our patients in this study are those patients with Barrett's esophagus undergoing radiofrequency ablation. This is not a general and universal Barrett's esophagus population. Our research has several important implications for clinical practice. First, since there was a lack of gender differences for Barrett's esophagus in African Americans and Asians, perhaps the utility of gender as a risk factor for the presence of Barrett's might be lower in these groups. Second, given that females and Asians suffered increased stricture rates, we should be cautious about over-treatment in this patient population, and reconsideration of dosimetry in this patient population might be necessary. This is especially true given the reduced length of Barrett's esophagus and generally lower degree of dysplasia that we found in women compared to men. Third, should females and Asians present with dysphagia symptoms after radiofrequency ablation, this population is more likely to reveal a stricture, which might be amenable to endoscopic intervention. This is compared to the Caucasian population. Thank you very much. I appreciate your time.